I'm a child neurologist at Columbia. Thank you so much for having me. I think I've met a lot of you guys before. I appreciate all those people who have joined me before clinically as well as at these research meetings who's had a skin biopsy on themselves or a child. Thank you. So we can all be siblings today because we're all going to show all of our skin biopsy scars. So I wanted to talk about today kind of going back a little bit from the science, but also just remembering how you kind of got here, right? Like you had to go to the doctor's office or a therapist to actually get this diagnosis and to be here, which is amazing. But it also really is going to make a difference when it comes to your everyday life. So I want to just kind of bring that piece back a little bit. As a disclaimer, I am a clinician, but I'm not necessarily your clinician. I'm happy to be your clinician. But you know, not everybody needs to come to New York City. But these are things that I think I want to empower you guys to remember that you can talk about with your clinicians, with your therapists, et cetera. So as a doctor, as a clinician, I'm not really sure how I got into the world of neurology, but I always ask the question why, right? So as a parent myself, you know, I see families every day and people come to me and they say, well, what's going on? I want to know why, right? We all want to know why, right? So parents come out of my office and they want to say, what is the diagnosis? And my job is to tell you, well, what I think is going on. What do I need to do to treat this or to support my child? And then what can I expect for the future? And this is kind of what I do every single day in the clinic. And what ends up happening is they end up getting this like piece of paper. If you've seen me in clinic, I have all these little circles and we write down like all of these descriptors: hypotonia, speech issues, feeding issues, toileting issues, self-injurious behaviors, epilepsy. And then we kind of have to go through as like a patchwork and say, okay, for that we can go on a medicine. There's no medicine for that. That's your educational support. Those are your therapies. Okay, you have to go to orthopedics to get those feet taken care of. And really that's frustrating, right? Like that definitely is a frustrating feeling. But the reality is parents want to know like, well, what's going to happen? What's going to happen in the future? I try to encourage parents to think about like, what do we need to do now? And what's the next transition point, right? Like we can't think about the future. Yes, that's important, but we don't want to drain ourselves there. So for me, I really try to say, what do we need to do now? What's the number one thing we need to do to help your child now? And then kind of what's the next transition point? Are we talking about going from early intervention to school age? Are we talking about going into our teen years? Because that does happen. Are we talking about being an adult? And those things, I think having that strategy is not as overwhelming for parents. We've kind of moved into this world now where it would be great if I could say, okay, is there something kind of starting from the top to kind of understand and describe that neurodevelopmental disorder? And then because of people like you guys providing that information to Combined Brain and Matrix and Simon Searchlight, maybe I can give you some information about what to expect for the future and give you guys some more support. And eventually, the reason why we're all here is to start talking about treatments, right? Not necessarily cures, treatments, supports that are really targeted. And so that's kind of how you guys got here, right? Is to say what along this pathway, going back to the clinic, really makes a difference. So what is a neurodevelopmental disorder? I actually, as a neurologist, it's one of those things you hear about, but you don't really know what it is. Basically, it's really important to know because it's quite common. 1 in 10 people in the United States and around the world have a neurodevelopmental disorder. It means it's a brain problem. It affects the developing brain. And so all of these things, global developmental delay, intellectual disability, cerebral palsy, autism spectrum disorder, ADHD, learning disorders in reading, which is what we used to call dyslexia, dysgraphia, mathematics. Those are all examples of neurodevelopmental disorders. And these are disorders that affect the developing brain. They do typically present in those first couple of years of life, maybe even months of life, but you might not necessarily see some of them until you get a little bit older, right? You don't get diagnosed with dyslexia until we actually expect you to start reading. It can affect a variety of brain functions: motor problems, communication skills, personal skills, social skills, academic skills, and occupational functioning. And importantly, the reason why we're here today is to talk about all those overlapping features and common comorbidities, which very likely have to do with all of those kind of underlying mechanisms of disease that lead to network problems, that lead to learning issues. And importantly for today, we know now that 30% of neurodevelopmental disorders have have some kind of genetic risk factor or genetic underlier. So thanks to Simon Searchlight, I actually peeked on, they just pushed out their 13th version, though you'll be hearing from our group at least about the 12th version. But what I wanted to do was actually look, thank you for all of you guys doing all those surveys. I know surveys can be fatiguing, but I wanted to look and just say like, well, what were the prior neurodevelopmental disorders that you guys wrote down? ADHD, autism, PDD-NOS, autistic regression. I put that in parentheses because it's not really a diagnosis, but maybe in the past we use that term. Learning disorders, intellectual disability, developmental coordination disorder, stuttering does fall under that category. And then guess what? And Med13L had like literally the same list. So there is definitely a common overlap between the groups, and not surprisingly, with most of the disorders in the Simon Searchlight cohort, as well as the combined brain cohort, we're talking about overlapping features. But then if we talk about other things that kind of go along with neurodevelopmental disorders, these are the things that we know commonly can happen in the brain too, but they're not necessarily falling under that NDD diagnosis, right? So we're talking about our challenges related to mental health and psychiatry, eating problems, toileting problems, eating, again, back to eating, more language issues, language disorders, problem speaking, low tone, which so many people here have had, putting things in your mouth, and sensory issues, and dysphagia, which is swallowing problems. So again, these aren't NDD per se, but there's certainly things that might be problematic. And guess what? It kind of matches when you look at the Med13 group. And I swear, actually, I literally sat there and looked at them all. They overlap, and it's not just CTNMB1 and Med13L. This is the brain, and this is what we're looking at all together. Now, importantly, when you have somebody that comes to the office and they have all these little diagnoses out there, you're kind of go to a clinician and you're hoping that they're going to be like, but what is my rare disease? We can't tell you that by just necessarily looking at you. That being said, there's definitely a lot of facial features and clinical similarities amongst specific groups. And that's where it's really exciting to think about genetics, right? And literally 2 weeks ago, the American Academy of Pediatrics finally came out with a statement that said, yes, for whole exome sequencing should be used first line. And this is really important. This is really exciting. And hopefully this will get people their testing sooner, get it approved sooner, and really start identifying more people to giving those answers why. So then you have that diagnosis, and then you go on this long journey, and I love all these long journey pictures. This is one from Nord. But then what do you do, right? So you have all these things, and you're like, within 3 days or hours, I already get the Facebook invitation to be friends with you. You're already calling Katie and Emily and being like, hey, where do I go, right? And you guys are like amazing families, right? You find your new families, which are amazing. You get to learn everything you can about this disorder. You become the expert. You're reaching out to the researchers saying, can you take my kid's skin biopsy, right? Like you're literally giving your child up for research so that like you can get closer to a treatment, to a cure. You find those expert clinicians wherever they are. You look into all those treatments. You find about all them. And then guess what? You go back to your doctor and you're like, hey, so we have Med13L and CTNMB1. And they're like, okay, what is that, right? And so, and I get that, and I certainly hear that, and you're laughing because it's true, right? Like you become the experts, and we know that. The reality is, in medical school, we already train a bunch, and like we're not going to be able to sit there and learn every single rare disease. And so, you know, it's really a partnership, right? It's a partnership between you and your clinical team to say, and your educational team to say, how can we work together to learn about what's going on? Okay. Now, things that you can use. Thank you to your community for coming up with gene reviews and using PubMed and publishing articles, because all the things you guys do here are going to be used to kind of circulate back to the clinic. Because the reality is, when you went to the doctor the first time, you wanted them to tell you, this is your diagnosis. I know exactly what this is. And it's frustrating that you have to go through this journey and keep kind of seeking that out. Now, the really cool thing is that like there's all these amazing organizations out there that are trying to help move this whole field forward and say, okay, for the field of neurodevelopment, how can we help move research forward so you're not recreating the wheel every time? That being said, I love all the flair and I love all of the wonderful logos and all the t-shirts, but everybody's like doing it over and over again. So how can we support them so that we can do it faster, right? So the power of a genetic diagnosis, actually, thank you, Rodney, for bringing this up, right? So who are all these cutie patooties over here? Well, they presented to their doctors with global developmental delay. Does anybody know who these people are? No. They kind of were ataxic and they had tremor. Raise your hand if you start knowing what we're talking about. Oh, Emily won. They have some seizures and epilepsy diagnosis. They have hypotonia. They have cerebral palsy, which is a motor problem, which I'll tell you about in a minute. And guess what? They have Angelman syndrome. Well, guess what? Did it even matter like 10 years ago that you had Angelman syndrome? Well, yeah, it did, because Alison Barrett now is like pushing this forward, and you have literally 3 phase 3 clinical trials for intrathecal medication. We're within literally a stone's throw of an FDA-approved medication. But the reality is, if you go back to it, what did they present with in the office, right? They had hypotonia, a little low tone. I know, 2 minutes, fine. All right, so back to the clinician's office. So you have this diagnosis, you go back, and they're like, okay, cool, this is interesting. My husband always says it's not cool to be the interesting case, but it is important. So I'm gonna tell you about coding and what that means. So who's heard of an ICD-10 code? I know the Med13L group has. So an ICD-10 code, now this is like the boring stuff that they don't tell you about before you go to medical school, but these are these codes, right? So we make up these codes by the World Health Organization in order to kind of communicate codes. So we take your child, who's a complex personal person, and then we try to put it into labels. Why do we do that? Well, we utilize that in order to better document things. So we can find patients with Med13L, and we can really make sure that we understand the medical record. We also do it for billing and reimbursement rates, because we know that we have to pay our clinicians for what they're doing, but it allows the insurance companies to say, okay, yes, we know that you're doing what you're doing, and we need to be able to understand why you're doing that. It also allows us to say, okay, why are all these people on medication X? Because we can look at all their ICD codes. And then furthermore, for the purposes of this, you can start identifying patients with specific genetic disorders, and maybe doing research in large data sets, kind of pulling out that information. And also going to the Hill and really advocating to saying these health policies are really important. We can go back to these codes. So some of the codes that you might see: genetic disorder. It's a totally blah statement. It means that, like, there's so many genetic disorders, so how can you utilize that? Well, you can't really. So that's why it's been awesome that you have community members that are trying to really advocate to saying, I want a Med13L ICD, and I want a CTNMB1. When it comes to epilepsy, we need that epilepsy code so you can get approval to get specific medications. Who has ever tried to get ABA, and who had hard time getting ABA because you didn't have autism listed on your ICD-10 code? So these are the logistical barriers that healthcare unfortunately has set up for you guys, but these are codes that are really important. Sometimes when you get denied billing services, medications, wheelchairs, any medical equipment, it's because you didn't have the right code. Not you, the doctor, but the doctor didn't know. So I just want you guys to be empowered to use your community to understand what are some of these codes. In order to get feeding therapy, it might be helpful to use that avoidant restrictive code down there. In order to get physical therapy, because in the United States they say you don't do it for rehabbing NDDs, you actually do it to fix something that's been broken. Well, that doesn't really make sense. Wouldn't we do PT for our life if you're going to need PT for life? My point is, there's lots of codes. There's thousands of them. Just kind of understand what that means, and kind of how, when you're talking to your insurance company and advocating with your teachers or with your doctors, what does that mean, and how can we use those codes? Just so we are clear, right? So epilepsy is a disorder where you have seizures, but there's a lot of different causes to epilepsy. And so typically what we do is we say, well, it's epilepsy secondary to this genetic disorder. Can you have both a genetic disorder and epilepsy? Absolutely. And so in this case, you can talk about something like cerebral palsy. The vast majority of people sitting in this conference right now have had a diagnosis of cerebral palsy. And I really want you to understand what that means. This is a common motor disability. All it means, it's a clinical picture of motor problems from birth. Delays in walking, delays in sitting, delays in using your hands, and having difficulty. It's an umbrella clinical term. This does not change once you get a genetic diagnosis. There's not necessarily a cure for CP, but guess what? We're moving towards treatments for the genetic causes of CP, okay? I'm gonna skip through that. Again, why else would you even use these terms like CP and autism? Well, you're going to go to your educational team to get your IEP. They're not going to know what Med13L is, and if you give them the gene reviews, that's helpful, but same thing. How are they going to understand what CTNNB1 is? But if you explain to them it's a genetic caused cerebral palsy, that's probably going to be much more meaningful to them, to your teachers, to your therapists, to your educators. What you want them to understand who your child is. So let's use terms that we can all understand and utilize easily. Unfortunately, fortunately or unfortunately, the DOE uses specific classifications. So am I going to be able to diagnose or classify your child under all of those? No, they have to pick one that they think is most helpful and most applicable to their educational needs. And so we can't describe a child based on one specific thing, or a person for that matter. So you need to utilize these different diagnoses for just the logistics of day-to-day. Dual diagnosis itself just means that you have more than one diagnosis. It's not really two. You probably have like 20 different diagnoses. My job is not to pathologize every single thing. It's just say, how can you use these words to describe your child who is a person and is very different? And from a holistic standpoint, how can we take each of these things in different settings and utilize them? It allows you to have complexity in your treatment plans and really personalize that medicine approach. Okay, you really need to be able to know who's on your team and who your child is. In my clinic, I often will say, well, everybody has a personality. Everybody has age-appropriate behaviors. I'm sorry, your child's gonna go through puberty. It just happens, right? But a diagnosis should go towards an intervention. Every one of those diagnoses should have an intervention. And so the goal is to say, what is the intervention I need now? Because this diagnosis is really impactful now. And then kind of looking at the future, each time reassessing that. It really allows for you to have that integrated care model, really having all these different professionals looking at different areas of your child, and you really need to build your care team. So I want to encourage you to say that you're going to need multiple people on your team. You're going to need neurologists and geneticists and psychiatrists and therapists and different specialties, and each of them are going to be going towards a different angle, right? Everybody wants the holistic provider who can look at everything, but that person really doesn't exist. You are that provider, and you need to identify who are the people that are important in your care model. I promise I'm almost done. We want you to understand, we want you to teach your educators and teach your therapists and teach the physicians, like who is my child? What do I need to learn about them? What do I need to understand to help care for them? So you can go and give them all the gene reviews you want and the PubMeds that you want, but you need to go and ask them, what is the specific thing that you can provide to my child today? You go to an orthopedic surgeon, look at my joints, great. You go to the neurologist, treat my epilepsy. You go to the psychologist, let's treat my behavioral challenges. And then you have to kind of put it all together. And another thing is that, like, yes, while you have your certain families, CTNNB1 and Med13L, there are other resources. So if you have an autism or autism concerns, you can go back to Autism Speaks and reach from their toolbox. You can go to the Cerebral Palsy Research Foundation and reach from their box. There's different organizations for different diagnoses. So don't be scared to utilize those things. Again, if we talk about rare diseases in the US, well, in the world, there's 7,000 rare diseases. We're not gonna know about all of them, right? You can't go to the Hill saying, I want everybody to take care of my child with my genetic disorder. Let's talk about rare disease as a whole, because that does affect 1 in 10 people if we talk about all rare diseases. And if we think about global policy changes, we're talking about global developmental delay and intellectual disability and cerebral palsy and autism. We're not necessarily talking about every single individual rare disease. So importantly, I just want you to remember that dual diagnoses are okay. You can use them, and they can be very logistically helpful for your life, and really to provide that personalized medicine approach that we really want. We want doctors to know who your child is, not just that label and that one ICD-10 code. All right, thank you.